ادعمونا بلايك للفيديو واشتراك بالقناة، فهذا يدعمنا كثيرا.
Clinical tests include percussion, palpation, cold and heat tests, electrical pulp test, periodontal probing, mobility, test cavity, transillumination, and radiographic examinations. In using any test, it is important to include control teeth of similar type to the suspected tooth or teeth. The results of the test on these teeth calibrates and provides a baseline for the patient's responses to tests on suspected teeth. Percussion is performed by tapping on the incisal or occlusal surface of a tooth with the end of a mirror handle held either parallel or perpendicular to the crown. This test should be preceded by gentle digital pressure to detect teeth which are very tender and which should not be tapped with the mirror handle. An additional approach is the biting test. For this test, the patient bites down on a cotton swab. Palpation. Palpation is performed by applying firm pressure on the mucosa overlying the apex of the suspected tooth. A painful response to palpation indicates periapical inflammation. Test cavity. After careful explanation of the nature of the test to the patient, preparation without anesthesia is done with a small and sharp burr. If the pulp is vital, there will be a sudden sensation of pain when the dentin is reached. In contrast, if discomfort or pain is absent, the pulp is probably necrotic. Cold tests. After the tooth is isolated with cotton rolls and dried, an ice stick or a large cotton pellet saturated with refrigerant is applied. Cold is more effective on anterior than posterior teeth. Heat tests. After the tooth is isolated with cotton rolls and dried, the tooth surface should be coated with petroleum jelly. Gutta percha heated in a flame is then applied to the facial surface of the tooth for this test. Another technique for heat test is to rotate a dry rubber prophy cup on the surface of a tooth to create frictional heat. Electrical pulp testing. After the suspected tooth is isolated with cotton rolls and dried, the electrode with a small amount of toothpaste is placed on the facial or lingual surface of the tooth. Using a lip clip or having the patient touch the metal handle completes the electrical circuit, and the level of current gradually increases until the patient detects it. The presence of response usually indicates vital pulp, whereas the absence of such a response usually indicates pulpal necrosis. Periodontal probing. Periodontal probing is an important clinical test that is often overlooked and underused for diagnosing periapical lesions. A periodontal pocket of pulpal origin is narrow. In contrast, periodontal pocket of periodontal origin is wide with different depths. Mobility. To determine mobility, place the index finger on the lingual aspect of the suspected tooth and apply pressure with the mirror handle on the opposite facial surface. Movement of more than 2 to 3 millimeters or depression indicates that the tooth is a poor candidate for root canal treatment. Transillumination. Transillumination helps to identify elusive longitudinal crown fractures and infractions. Place the fiber-optic light from various angles and different distances to the suspected tooth or teeth. Transillumination produces contrasting vertical dark and light segments of the tooth at the fracture site. Radiographic examinations. Periapical as well as bite-wean radiographs are essential for the examination of mineralized tissues. Radiographs allow detection of carious lesions, defective restorations, quality of root canal treatment, abnormal pulp and periapical appearances, the relationship of the neurovascular bundle and maxillary sinuses to the apexes, and any bone loss due to periodontal disease. They may also reveal structural changes and bony disease unrelated to the teeth.